Hello viewers, in today's lecture, you will be learning in detail about arch expansion, which is the modality of gaining space in orthodontics, its mechanism, the types, and also the appliances.
So to begin with, we as orthodontists, we resolve various malocclusions and for that we require space in the arch. Now this space can be required if we want to retract the anteriors, if we want to resolve the crowding, right? And many a times we also have number of impacted teeth. We have cases with impacted teeth, and to bring these impacted teeth in the arch we require space. So we'll discuss about the modalities which can give us space. So I have a mnemonic of my own, that is DMAP, DWPMAP. So with this you'll be able to enumerate the methods. So D stands for distalization, E is for extraction, E is for expansion, P is for proximal stripping, also known as interproximal reduction or IPR. Then for M, we have molar uprighting. Many a times the molar can be tipped into the space, and by uprighting the molar we might gain some space. A stands for the anterior proclination. So in cases where the anteriors are retroclined, so when we push them out of the arch, when we procline them, we'll gain some space. Then we have P, right? P is for posterior derotation. So many a times you have all these options and you tend to confuse whether it is posterior derotation or anterior derotation. So let me show you. This is the arch and this is the central incisor, and this is central incisor that is rotated. So you can very well make out that a rotated central incisor will get less space in the arch as compared to a normally placed central incisor. So when this incisor that is rotated is derotated with some orthodontic mechanics, it will need some space. It will not give us space. Therefore, when asked a modality that will help us to gain some space, it will be posterior derotation and not anterior derotation. So in this lecture particularly, we will be talking about expansion. We'll be discussing the indication, contraindication, the anatomy, what happens, what are the appliances, right? So to begin with, we'll discuss some of the history of that is associated with the maxillary expansion. So history first of all. So you need to remember this name, the year, the appliance. So in 1860, Emerson Angel was the person who came up with the rapid maxillary expansion device. So this person is also known as the father of rapid maxillary expansion. So kindly do not confuse this Emerson Angel with Edward Angle, who is the father of orthodontics. So this person gave us a device for expansion. So with this appliance he was able to gain 1/4 inch of a space in 14 days in a 14-year-old child, right? So I'll show you the figure. I have an image gallery. We'll be seeing the appliances also simultaneously. So this first appliance you see, this one was the one given by Emerson Angel, right? So you can see there is a screw in between which will cause expansion, and there are these bars which take anchorage from the posteriors, the premolars and the molars, and causes the maxilla to expand, right? So this was the appliance. Now moving on, next we'll talk about the indications of the maxillary expansion therapy, right? So we'll do the indication first of all. So a malocclusion has three components: a sagittal, vertical and a transverse component. So with expansion, we are taking care of the transverse deficiency with which the patients present. So therefore, very simply, the first indication would be crossbite, that is posterior crossbite. Now what is crossbite? According to Graeber, it is any abnormal positioning of one or more teeth, either buccally or lingually, in respect to the corresponding teeth. So if you talk about the crossbite in this case, we are talking about a crossbite in which the maxillary posteriors, they lie lingual to their mandibular counterparts because of the deficiency in the intermolar width or the deficient size of the maxilla. So this will benefit with expansion, right? So first indication is the posterior crossbite. So if we come to the second indication, it is as an adjunct to functional appliances, functional therapy and surgical orthodontics. So what happens in class 2 cases when you're trying to bring a mandible in a forward position, there are many much chances that you might be gliding the narrow part of the maxilla over the wide part of the mandible. So see, when the patient already has a class 2 malocclusion, although there is a class 2 deficiency, there is a sagittal discrepancy, but it might be possible that the transverse relationship is normal. So when we glide this mandible forward in a normal class 1 relation, it is possible that the wider part of the mandible might come in contact with the narrow part of the maxilla. So now, to ensure that there are well coordinated arch after debonding, after finishing of the case, this expansion becomes an important adjunct for these cases. So same is for the surgical advancement with BSSO, and same is for the functional therapy. So this is the second indication. So third indication is also similar. It is distalization. Now instead of taking the mandible forward in class 2 cases, if we take the segment of the maxilla backwards so as to correct the class 2 relation, even then it can cause crossbite. So if we want to correct that, we need to expand. Fourth indication is mild crowding. So after we have done the diagnosis, and when we are planning the treatment, it is very important to differentiate between an extraction and non-extraction case, right? Because extraction therapy is invasive. So for non-extraction modalities, expansion is one of them, because mild crowding can be resolved with some amount of expansion in the arch because it will give us space. Next is with orthopedic traction of maxilla in class 3 cases. So in class 3 cases in which the maxilla is retrusive and in the patient who have some growth potential, so with the use of face mask therapy, we can retract the maxilla forward. Now this becomes very important indication because it has been found that when a protocol of expansion is done prior to the retraction of the prior to the traction of the maxilla, the circummaxillary sutures become loose. So they help us in easy traction of the maxilla as compared to traction with face mask alone. So this is an important point. So a therapy of expansion prior to traction with face mask, what does it do? It loosens the circummaxillary sutures. So this is an important indication. Now if we talk about the sixth indication, now sixth indication are the medical indications. So because the maxilla is expanding and it is also in contact with the nasal floor, so it has been found that around 45% to 60% of the nasal resistance is reduced with the therapy of expansion. So this can be used in cases in which there is a deviated nasal septum, there is problem in breathing, there is a deviated nasal septum. Then in cases where there is increased airway resistance, right, and there are nasal airway abnormalities. So in all these cases, expansion can be used. So now we have covered the history and the indication of the expansion therapy. Now let us come and discuss and have a look at the anatomy of the maxilla. So it will help us to give a better idea when we'll talk about the modalities. So talking about the mid-palatine suture, first of all, if you see the maxilla from the occlusal view, so it is made up of two bones, one is maxilla and second is the palatine bone. So this anterior half is made up of palatine process of the maxillary bone, while the posterior part, this one, is made up of the palatine bone. So these two sutures, that is the intermaxillary and the interpalatine suture, they together, both of them form the mid-palatine suture. So across this suture, the splitting will take place and hence the skeletal expansion will take place across this suture by splitting both the halves of the maxilla. So this was about the anatomy from the occlusal aspect. Apart from that, the maxilla is in contact with multiple bones. For example, the frontal, the ethmoidal bone, the zygomatic bone, the sphenoid bone, we have vomer, and of course the palatine bone, as we have seen occlusally. So it is very important to know at this point that zygomatic and the sphenoid bone especially, they are responsible for a buttressing effect. So any manipulation of the maxilla is resisted by these two bones. So zygomatic and the sphenoidal bones are the one which give a buttressing effect to the maxilla. So apart from this, you can also note that most of the extensions of the maxilla are in the superior and posterior direction. Therefore, they leave the anterior and the inferior aspect of the maxilla free. So we'll come the implication of this later. So but you need to remember that in the maxilla, it is mainly bound in the superior towards the frontal and the posterior aspect, but the anterior aspect and the inferior aspect of the maxilla, that is towards the occlusal plane, is relatively free as compared to the other directions. So this was the anatomy. Also, you need to remember that there are certain values of age of the ossification which have been established in literature. So according to Bertie Malson et al., the age for ossification of the mid-palatine suture, for females it is 16 years and for male it is 18 years, right? So beyond this, any manipulation of the suture will lead to dentoalveolar effects as opposed to the desired skeletal effects that might be required in the case. Now we have covered the anatomy. Now let us have a look at the classification of expansion. So I'll be teaching you two classification. First is very simple, based on the rate. Based on the rate, it can be slow expansion or it can be rapid expansion, right? So very simple, based on the rate of expansion, the rate of activation we are doing, it is slow or rapid. And second classification is given by McNamara. So over here I would like to point out a few things. So I have given you an age of ossification of the mid-palatine suture, right? So there is an age of ossification of this particular suture. So there are some appliances even in the slow type of rate of expansion which are associated with skeletal type. But traditionally, the slow expansion is also known as a dentoalveolar expansion. So when you get this question in the exams and you read this word dentoalveolar expansion, they are either talking about slow expansion cases or they are talking about adults in which the ossification of the suture has already taken place. So you also might find some questions. For example, the quad helix appliance, which we'll cover later, falls in the slow category of expansion, but when given in earlier stages, that is prior to ossification, leads to some skeletal effects, but after ossification will lead to dental effects. But we cannot get confused. So whenever this term comes dentoalveolar, you need to think about the slow expansion or expansion which will be done in adults. So talking about the classification given by McNamara, so he has divided the classification into three types. So first classification is dental, second is skeletal, and third is passive. So dental expansion is also known as dentoalveolar or orthodontic expansion, dontic meaning the teeth, dental, right? Orthodontic expansion. So this can be achieved by using some removable appliances with conventional orthodontics, that is wires. So in this case, what is happening? There is buccal tipping of the crowns of maxilla. So when you will see, you will feel like expansion is happening, but this expansion is dentoalveolar in nature. So if you see the cross section of the arch, the teeth, they will buccally tip and the crowns will tip lingually. So this will cause some dentoalveolar expansion, right? Now coming to the skeletal kind of expansion, it is orthopedic kind of expansion, right? Because it is skeletal. Now this usually happens with the fixed appliances, and in younger individuals it will happen only in younger individuals, because only then there is a scope of expansion and splitting of the two halves of the maxilla. So in this, actually there is skeletal expansion, there is splitting of the maxillary halves. And passive expansion, in this we are doing nothing but we are shielding. So as we know, in a normal state, your teeth in the dental arch, they lie in an equilibrium. So they are in equilibrium with the buccal and the labial mucosa and also your tongue. So in passive kind of expansion, we are just shielding it and we allow the maxilla to grow and we allow the mandible to grow according to the growth potential. So this thing is applied when we deliver an oral screen. So when we deliver an oral screen to the patient, or we give a Frankel appliance. So this principle of passive expansion is applied in those cases. Now let us have a closer look and understand in details the two kinds of expansion, that is rapid and slow. So starting with the rapid kind of expansion. So first we'll discuss about the appliances that have been used. So these can be removable appliances or fixed appliances. So the removable kind of appliances, they have a jack screw in the middle. So if this is the plate, I'll show you the diagram also. If this is the plate, there is a screw in the middle and it is retained on the teeth by using clasps, right? And there is a split in the acrylic in the middle. If we want to have some differential kind of expansion, maybe more in one side of the area as compared to the other, then we can not split it from the center, we can split it differentially. Like we can split it from the other angle, and this can be one larger part which we want to move less as compared to the other part. So this is removable, but the disadvantages are for this particular thing is that it is based on the compliance of the patient. So in rapid it is more traumatic, we are doing more activations, so it is usually considered that it is, since it is dependent on the compliance of the patient, there will be no skeletal expansion with such removable appliances. So for rapid we avoid giving removable appliances altogether. Now coming to the fixed kind of appliances that we have, so there is a more elaborate classification of the fixed appliances. Let's have a look at this. So these can be divided into tooth-borne and tooth and tissue borne, right? So let us have a look at the tooth borne. So for you to remember, you can remember it by using a mnemonic, that is HIT. T is for tooth borne, H and I, hit, right? So when you get a question about tooth borne, you need to remember the mnemonic hit and you'll come to your mind there can be two appliances, either H or either I. So H here stands for the Hyrax appliance and I stands for the Isaacson appliance, right? And in the tooth and tissue borne we have two appliances, D and H. So we have Derichwiller appliance and we have Haas appliance. So let's go to our image gallery and have a closer look at these appliances, so you'll be able to identify better. So there have been questions in the past, so they have given a figure of these diagrams, they have given the images, and then you need to identify what is happening. So let us have a look at these first two appliances which you see on your screen. So very first of all, when you see a such expansion appliance with a screw, an appliance with a screw will obviously give an expansion appliance. Now you need to divide it whether it is a tooth-borne appliance or it is a tooth and tissue-borne appliance. So when you see this acrylic portion that is covering the palate, you immediately need to make out that it is taking support from the tissues as well, right? So there can be acrylic on the occlusal aspect, but when you see acrylic on the palatal aspect, it should be a signal that this is a tissue-borne appliance. So these two appliances are tooth and tissue-borne, right? Tooth-borne, because tooth-borne they are by default because they take support from the premolars and molars. Tissue because you can see an acrylic plate that is taking support from the palatal tissue. So therefore these are tooth and tissue-borne appliances. So again there are two appliances as I mentioned, D and H, that is Derichwiller appliance and then we have Haas appliance. So now to differentiate both of them, so you can see in the Derichwiller appliances there are tags. So obviously there is banding on the premolar and molar on both the sides like in other appliances, but you'll also see that there are tags which are given on the premolar and molar. So this is to engage the acrylic better. So this is your Derichwiller appliance which comes with tags. Second appliance in the tooth and tissue-borne category is the Haas appliance. This is the Haas appliance. So again there will be banding of the premolars and molars. There will be a thicker wire given both buccally and lingually, but the lingual wire is folded inwards and is longer in size so as to again engage the acrylic. So if you want to remember how to guess this appliance, obviously it is tooth and tissue borne, but it also forms an H shape, right? With these lingual tags it forms an H shape. So this is Haas appliance. Now coming to the second category of appliance, we have tooth-borne appliances. So under tooth-borne, again what was the mnemonic I told you? On the tooth-borne you have H, I and T, right? Hit. So it can be either Hyrax or it can be Isaacson appliance. So the first appliance that you see over here, again there is banding of the premolar and molar, and there is a band material or sheath which is given on the both buccal and lingual sides, and there is a special kind of screw. So this is the nut and this is the screw. So this nut is activated, that it is pulled more towards inside such that such that the spring, it becomes more activated, more compressed, and therefore it gives a rebound force on the posterior segments in order to cause the expansion. So this appliance is the Isaacson appliance, right? Again, if you want to remember it, it is not a tooth and tissue bond because there is no acrylic, so it can be the Isaacson or it can be Hyrax, but if you see closely, it is like an eye which is laid horizontally, so it is a Isaacson appliance, right? So in this, there a special kind of screw is used, that is mini screw. This is MINNE screw. So this is so because it was invented by Minnesota Dental School, so therefore the name is mini screw. The second appliance that you see is the Hyrax appliance. So this is a special Hyrax screw, right? So it will be easier to identify because it is not tooth and tissue bond, and it is not a circular screw like that was seen in Isaacson. So this is the Hyrax screw. This is the Hyrax appliance. So even Hyrax appliance come in two forms. It can be either banded like this one, or it can be bonded. Bonded in the sense that there can be some occlusal covering. Now this occlusal covering can be either of cast and splint type, or there can be an acrylic covering. So this cast splint is usually made up of silver copper alloy, and the acrylic is a normal cold cure alloy that we use. So this is usually 1 to 2 millimeter in size. So talking about the indications, so we'll study the effects also of expansion. So one such effect is opening of the mandible and extrusion of the maxillary molars. So this occlusal covering, it prevents the opening of the mandible. Therefore it is used in cases which have a towards horizontal growth pattern. This is the first indication. The second indication is mixed deciduous dentition. So there is frequent exfoliation. So the wire bending that you do now might become useless later. So it is used in mixed dentition cases also because there is a reduced chairside time. So because there is reduced need of extensive wire bending, there is reduced chairside time and can be delivered efficiently. So now talking about this special screw that you see over here. So talking about the screw details. So this screw is, as you can see, it contains a hole over here. So if this is the screw on both sides, these are equal on both the sides, and expanding will open it on both sides equally. So you will see a screw at the center over here where the key is put and it is activated. So the one full turn, that is 360 degree. So the distance that is covered in one full turn, or the amount of expansion that is expressed while transversing this distance, is called the pitch of the screw, and for Hyrax it is 1 millimeter. So therefore every 90 degree turn is equal to 0.25 millimeters. So this is about the specifications of the screw. Now coming back over here, so now we have studied the appliances that can be used. We have studied the classification. So yes, you can identify this image also. So I have kept it as a comparison. The screws might look familiar, but if you have understood what identification marks I have told you about, you will be able to identify this appliance. So if we see this appliance, you will see an acrylic covering, right? This acrylic covering you can see. So therefore it is a tissue bond appliance, tooth and tissue bond appliance. Now what exactly, it can be either Derish filler or it can be Haas appliance. So Derish filler, as you know, there are tags that are seen. So these tags, if you can see on your screen, these tags are seen in the Derish filler appliance. So this is your Haas appliance, right? And this, because there is no acrylic present on the palatal surface, so it is tooth bond appliance. In tooth, it can be either H or I. It can be Hyrax appliance, it can be Isaacson appliance, but because you do not see the specific longitudinal laid down screw, so this is your Hyrax appliance, right? So you might be asked this question about to identify the appliance and to classify, right? So now we have covered the appliances. Now let us study the effect of expansion. We will be studying the effect of expansion. First of all, firstly on the maxilla, it is a maxillary appliance, so it will definitely have some effects. So what we are doing, we are splitting the suture, we are splitting the maxilla, we are splitting the two parts of the maxilla from the suture. So what is happening, again to bring the previous point, the anterior and the inferior end of the maxilla are relatively free. So if you see the expansion that has taken place from the occlusal aspect, it is not parallel, it is fan shaped. It is fan shaped like this, right? So it is more in the anterior region, that is between your incisors, and less as you move towards the soft palate, right? This is occlusally. And if we see frontally in the radiographs, if this is your nasal aperture, this is your maxilla, your expansion again in this section also will be fan shaped. It will be more inferiorly as compared to the upward as we moved cranially, right? So this is about the implications. So apart from this, what else is happening? There is downward and forward movement of the maxilla. So let us see a figure to understand the same thing. Right, so this is the figure which I was talking about. Since the anterior and the inferior end of the maxilla are relatively free, there will be more expansion in this area. So another peculiar thing that you can see here is the midline diastema that is present between the central incisors. This is one of the very important clinical indications if you want to check whether the expansion has happened or not. So this brings us to the effect on the maxillary dentition. So this was about the maxilla. Second is the maxillary teeth or the maxillary dentition. So there is a very characteristic midline diastema that develops. So this diastema is half of what the expansion has happened. So if expansion that has happened is 4 millimeters, this midline diastema will be around 2 millimeters. But this is self-corrective and it usually closes between 3 to 4 months. Why? Because there are the interseptal fibers. The interseptal or the transeptal fibers between the central incisors are still present and they'll close the space. So this is about the anteriors. In the posteriors, there will be eruption or there will be extrusion of the maxillary molars, as we previously discussed. So what will happen with the extrusion of the maxillary molars? It will have some effect on the mandible. So when the maxillary molars will erupt, it will cause the mandible to open, right? So it will cause some more vertical growth pattern. So in patients who already present with vertical growth pattern, their facial form will become even deteriorate because it will become more long. So therefore it will cause opening of the mandible. So this is one of the contraindications of the maxillary expansion, that it is not to be given in those patients who have a very vertical growth pattern, because again there can be some extrusion of the maxillary molars which will drop open the mandible. So in the mandible there is opening. And the fourth effect is on the nasal aperture, the nasal floor or the nasal cavity. So there will be reduction in resistance or the airflow, which as I have mentioned previously, the reduction is by about 45 to 60%. Right? So this is about the effects. Now let us talk about the contraindications. So we have understood the contraindication, we have understood about the devices, we have understood about the effects. Now let us discuss the contraindications of rapid maxillary expansion. So when they should not be given, when there is a single tooth crossbite. So ideally they should not be given, because these can be resolved by using simple appliances such as finger springs, some clasps. So there is no need to give such extensive appliances. So second will be skeletal asymmetry. Now because the expansion will be bilaterally, so if you give it in a skeletal asymmetry case, you are not solving the problem, rather you are just expanding, but again the asymmetry will still exist. So clinically, this is a clinical tip. So whenever a patient presents with a midline deviation, you need to see if the patient actually has a laterognathia or if the patient has a lateral occlusion. So what is the difference? I'll tell you. So when the patient has a lateral occlusion, when the patient closes, the midline will not match. But when the patient opens the mouth wide, the midline will start to match. While in laterognathia, the midline will be shifted even if the mouth is closed or open. Now what do you understand by this is that, so many times the maxilla is constricted, right? There is no occlusion. So for the comfort of occlusion, for the comfort of biting, for the comfort of function, the patient gets into a habit of occluding at least one side of the posteriors. So this can lead to a lateral occlusion. So although there is a midline shift, but this is caused by the constriction of the maxilla, right? So when the patient opens, the midline is matching, but when they closes, the midline is deviated. So this is a lateral occlusion. While laterognathia is an actual problem, it is skeletal asymmetry. So in this case, in case of laterognathia, the expansion will not help. But in case of a lateral occlusion, or when the patient comes with a unilateral crossbite, and when we, according to analysis, we see that it is actually a lateral occlusion, so in this case maxillary expansion is indicated, because it will give us posterior stable occlusion on both the sides, right? So this is about the second indication. If we talk about the third contraindication, these are the vertical growers. So we have discussed previously, because it will rock open the mandible. Fourth is about the uncooperative patient or non-compliant patient. So this is a normal contraindication in all the appliances. So whether you give normal brackets, normal braces to the patient, if the patient is non-cooperative, if they do not wear the settling elastics, the results will be suboptimal. The fifth contraindication is periodontally weak teeth, because so much force is being applied to the, so although the force is being applied to the suture, to the bone, but it is applied through the teeth, so the periodontally weak teeth will again be harmed when giving such huge amount of forces, right? So this was about the rapid expansion. And the final indication, final contraindication, is in those cases where the ossification is completed, because again, if the ossification has completed, there will be no skeletal expansion, there will only be dental alveolar expansion that you can gain by normal appliances also. So there is no need to give a rapid palate expansion device. So in such cases, who are above this age of 16 years of female and 18 years of male, there is an option of getting a surgery which is adjunctive to this expansion. So this is also known as the SARPE, or surgically assisted rapid palatal expansion. So in this, what is done, the suture again is cut open, and then the expansion device is given so as to allow the expansion to get the control of the arches, and then they can be expanded. But this has a contraindication, because first of all, they have a problem disadvantage that again they are very invasive, and second thing is that they have a very high relapse rate, because at this age, once the ossification has occurred, even the mucoperiosteum of the palatal surface, it becomes very inelastic. So even though you may be able to achieve good amount of posterior occlusion, but again there are many great chances of relapse with this case. So we have done about the rapid expansion, we have done the contraindication. Now let us come to the second type of expansion, that is slow expansion, which I have mentioned. You need to remember, it is used traditionally as a synonym with dento-alveolar kind of expansion. So before going into the appliances, we will compare the slow and rapid expansion, right? So slow and rapid expansion. So first of all, if it does, so these are differentiated based on the rate, right? So the rate with slow expansion, the rate of expansion in slow type of expansion is 0.5 to 1 millimeter per week, while with rapid it is 0.5 to 1 millimeter per day. So you can see the difference, huge difference. That is the difference in the rate of expansion. If we come about the type of tissue reaction, it is more physiologic, because lighter activations are done as compared to rapid, which is more traumatic. So in this rapid type, you're basically tearing apart the suture. You're tearing apart the suture and then bringing both the parts apart. So that is about rapid. If we come to the slow, so this principle behind slow expansion is that they use gentle biocompatible forces such that the expansion is equal to generation. So obviously it is more physiologic. So if we talk about the activation, it is less frequent with slow expansion, and it is more frequent with rapid expansion. If we talk about the total time taken, the total schedule that it cost us, it will be around 2 to 3 months with slow expansion, while with rapid it is only around 1 to 2 weeks. If we talk about the relapse rate, it is less in slow because it is physiologic, less traumatic, and it is higher with rapid expansion. If we talk, therefore it goes without saying that retention will be more of a problem in rapid kind of cases as compared to the slow. So even though you're doing slow, you're taking this much time with slow expansion, but the retention time is considerably high with rapid expansion. So the retention period is usually around 3 to 6 months with rapid appliances. So this was about the difference between both the types of expansion. If we talk about the appliances, with rapid expansion, as mentioned previously, rigid or fixed appliances are used, while with slow, both removable and fixed appliances can be used to get space into the arch. So this was about slow expansion. Now let us have a look at the appliances that can be used. So they can again be removable or they can be fixed. The removable appliance again can incorporate a jack screw in the middle and can be opened according to the slow schedule. And for other appliances can be coffin. So this appliance, coffin spring appliance, was given by Walter Coffin. So this incorporates a wire of 1.25 millimeter into the acrylic plate. So I'll show you a figure, but there is an omega shaped loop and between the acrylic and these two can be activated by either pulling it apart manually, because the spring is a little flexible, so either you can pull it apart manually, or you can activate it by using a 3-pronged plier. Right, so let us have a look at the appliances in the gallery. So these are the two appliances, two removable appliances which can be used. So as you can see, there is a jack screw in the middle. It has glass for retention. This is a removable appliance which is used for slow expansion. This has a jack screw in middle. This second figure is about the coffin spring given by Walter Coffin. So you can see this omega shaped loop in the center. We have glass for retention. These can be pulled manually. So this is the second device, second removable device, which is used for slow expansion. Right? Now let us come to the fixed appliances that have been used for slow expansion. Fixed appliances. So for this, our normal orthodontic treatment, the orthodontic wires can be used, because these can be expanded by around 10 millimeters at least to get some expansion in the arch. So this can be done at around 21-25 wires. So rectangular wires have a better torque control. So usually such expansion is done at rectangular wires, or they can be done by using auxiliary wires. So these auxiliary wires can be of length around 19-25 wires, which are used over the main base wire, or they can use a round very heavy wire that can be around 1 to 1.13 millimeters in diameter, so as to bring about the expansion. So this is about the orthodontic wires, or the normal orthodontics that is used. The other appliances that are used as specific appliances include quad helix. Quad helix is a very important appliance. It has been given by Ricketts. So there have been questions that in the past, so they have asked about an appliance in slow expansion type of category, which can be used for both skeletal and dental type of expansion. So this quad helix, usually it is given in cleft patients, and it is found to be equally effective with the normal Hyrex expansion, Hyrex type of rapid expansion. So when given before the ossification period, it can cause some skeletal expansion also, while given after the ossification period, it will cause dental expansion. So there was one such question in the past. So they have asked about the quad helix, an appliance which can cause both skeletal and dental kind of expansion. So quad helix is that appliance. It was given by Ricketts. So if we study about this, just a minute. So quad helix appliance. So there are two anterior helices, two posterior helices. There is an anterior bridge, there is a posterior bridge, palatal bridge. This is anterior bridge, this is your palatal bridge, and there are outer arms. So now if we talk about the expansion, if we activate the anterior region over here, it will cause flaring of the posterior arms. So therefore, it is important, it might be confusing, but it is important to remember, activation in the anterior region or the anterior bridge will cause expansion of the posterior region. So if you want to expand the posterior areas, you will activate the anterior bridge. Either you can de-cement and do it manually, or you can use the 3-pronged pliers. So what I'm talking about is 3-pronged pliers. So they have 2 prongs on one side and 1 on the other, and then the wire can be pressed in between, right? So if we activate the anterior bridge, it will cause posterior expansion, while if we activate the anterior bridge, the posterior palatal bridge, it will cause anterior expansion, as it will cause the flaring of the outer arms, right? It will cause flaring of the outer arms. So if we talk about the material with which the appliance is made, usually it is stainless steel, and it is 0.038 inch of stainless steel wire, which is used for quad helix. Now better version of quad helix has now come in the market, which is the NITA expander. So this NITA expander was given in 1993 by Arndt et al. So I'll show you the figure. So this is first of all your quad helix. There is a These are anterior helices, posterior helices, anterior bridge, parietal bridge, outer arms, and this over here is your NITA expander. So the NITA expander has two components. One is the thermal activated NITA in the center, these two wires, and this outer arm is made up of stainless steel. So it uses two properties of NITA, that is shape memory and thermal activation. So this wire has a transition temperature of 84 degree Fahrenheit. So above when the temperature is cold, there are reduced atomic bonds, interatomic forces. So this causes the appliance to become more flexible, right? So clinically, if you have to use this expander, what you have to do is you have to rub it, you have to put it in ice cold water, or you need to rub it between the ice cubes, or you can use your ice spray that usually people use in conservative dentistry. So with that, because it is a lower temperature, the interatomic forces will reduce and it will become flexible and very easy to insert in the patient's mouth. So after you have inserted, gradually because of the increased intraoral cavity temperature, the transitional temperature will increase, and because of the shape memory, it will return to its original size and it will cause the activation of the appliance. Now because it is hot, there will be increased interatomic forces and it will become more rigid. So this is about the NITA expander. So this is the NITA arm, and this is your SS arm that is used, and if the given below is the recent type of NITA expanders. So now they come with a single wire of NITA, and obviously the arms are still present, the outer SS arms are still present. So if you talk about the measurements, so it is about outer arm is 0.032 and the NITA is about 0.035, right? So it comes in 8 sizes, 26 to 47 millimeters. And if you want to measure, if you want to purchase it, what do? You measure the intermolar distance and then you add plus 3 millimeters to it. So that will be the size of the expander which you need to purchase and which can be inserted in the patient's mouth and it will be, patient will be compliant also with this much of activation. So this was about the appliances. Now there is a very important thing that you need to remember. Again, it has been asked, so I'll take you here. So this is the activation protocol. So the question has been asked several times about the activation protocol with rapid maxillary expansion. So there are two that you need to remember. One is given by Timms. So Timms has his whole book on the expansion devices, right? So Timms, according to Timms, in younger patient that is less than 15 years of age, you need to activate by 90 degrees, that is this one turn in morning and one in evening. While for adult patients that is greater than 15 years of age, there will be 45 degrees of activation, that is not one complete turn, rather 45 degrees 4 times a day. So although the activation is same, but the frequency is more in the adult patient as compared to the younger patients. So this was given by Timms. The second one is given by Zimring and Isaacson. So in younger patients, there will be 2 turns for 4 to 5 days, that is 2 90-degree turns, 180-degree whole turn in full day, 2 turns for 4 to 5 days, and after this there will be 1 turn every day till the desired expansion has been achieved. While in adult patients, there will be 2 turns for 2 days. This will be followed by 1 turn for 5 to 7 days, and then 1 turn every alternate day. So I know this is something you will to mug up, इसमें बहुत understanding नहीं है, but then this is the activation protocol given by Timms and given by Zimring and Isaacson, and it can be asked. Even the table which differentiates between the slow and the rapid type of expansion can also be asked, and it has been asked. Now come.
So that was all for this lecture. I really hope you were able to understand the concept of arch expansion, and in case of any doubt, you can drop your comments below.